As you're all aware, cardiac imaging is absolutely essential for diagnosis and management of coronary artery disease. In this regard, cardiac CT, the multiparametric cardiac CT, has of late proved to be a very superior tool. So much so that several guidelines, including the NICE, European Society of Cardiology, AHA-ACC, and SCCT, the Society for Cardiac CT, have all recommended this and given a class 1 recommendation for certain situations. This is a diagnostic procedure of CT shown as a timeline. The CT toolkit enables anatomic assessment in the form of assessment of stenosis severity and calcium score, plaque characterization, determination of hemodynamic significance by way of CT-SSR, evidence of objective evidence of inducible ischemia by CT perfusion, and most important, coronary inflammation, which can be assessed by perivascular fat attenuation index. It gives elegant three-dimensional pictures and it has a very high negative predictive value for ruling out coronary artery disease. These are the high-risk plaque features seen on CCTA, that is positive remodeling or the Glago effect, low density non-calcified plaque, spotty calcification, and napkin ring sign, that is due to circumferential necrosis. These are considered to be high-risk plaque features and associated with adverse prognostic features. Any coronary calcium score above 0 is far more sensitive in predicting MACE, major adverse cardiac events, as compared to a positive stress test. Multi-formatted display of coronary atherosclerosis, value-added iterations like CT-FFR and CT perfusion, ventricular function analysis. Of late, artificial intelligence, deep learning, and machine learning have also been incorporated in the characterization of not only calcium but also coronary artery disease, the plaques, and segmentation. Besides prognostication based on total plaque volume and diameter stenosis. It elegantly proves or demonstrates instant and in-segment restenosis as well as block grafts. Risk stratification is possible by CTA based on the degree of stenosis, the number of vessels involved, the plaque characteristics, and it is also possible to predict the probability of having ACS based on these features. Fat attenuation index is something new. It assesses coronary inflammation. Basically, a coronary inflammation, that is the inflammation in the wall of the coronary vessel, elaborates cytokines. So these cytokines by signal transduction pathway have an effect on the perivascular or pericoronary adipose tissue, and it causes depletion of adipocytes. It also influences the transcription, that is genetic expression, and creates adipocytes which have low quantity of fat. Besides the increased water content, tissue water content, and cellular inflammatory infiltrate, all of them lead to a decrease in attenuation, which can be elegantly imaged by CTA. So this confers, or this shows the residual risk apart from the stenosis severity and plaque characteristics, and to a certain extent explains the paradox of people with non-critical stenosis getting MIs. It's useful for prognostication also. It can be incorporated in clinical care pathways and risk stratification models. So much so that CCTA can be used as a one-stop shop in evaluation of patients with chest pain. This slide shows a comparison of the various parameters, the advantages and disadvantages, which the previous speaker has also mentioned. For evaluation of high-risk plaque features, CT-FFR and FAI, one requires dedicated software. Stenosis severity can be underestimated in densely calcified lesions, and calcium score, of course, misses the non-calcified plaques. The performance of CT biomarkers. So how does one go about? So first is choosing the right diagnostic test. So we start a probability-based structured evaluation followed by risk stratification and allotment into of patients into what are known as coronary risk profiles. So basically, we have the low, intermediate, and high. So it is a patient who's less than 65 years who belongs to this intermediate high category with less than severe suspected disease. This is a group in whom the CCTA is favored. Besides, of course, other situations like anomalous coronary arteries. So pretest probabilities can be estimated by different models. This is one which shows a model based on age, gender, symptoms, and calcium score. And there are other tools like heart pathway, ADAX, and ADAPT. So this is an acute chest pain pathway wherein the patients are triaged into STEMI, non-STEMI, possible ACS, and non-cardiac etiology. So it is this possible ACS which is useful, which is in whom CCTA is useful. So after doing the CCTA, the lesions are classified based on the RAT score, which has been described by Society of Cardiovascular CT, and thereafter management strategies instituted. Which I mentioned, this is what I had mentioned earlier. So it is chest pain level 4, that is low to intermediate risk ACS, which is most suitable for coronary CTA, and certain patients who belong to the subset of high risk ACS. For STEMI and non-STEMI, invasive coronary angiography is the best option. Similarly, post revascularization, either after stenting or after CABG. So this is a algorithm for evaluation of chest pain in a patient with chronic stable CAD. After excluding left main stenosis by CCTA, patients are further subclassified based on the same RATS pathway, and thereafter management instituted. So for mild stenosis, RATS1 less than 25 and RATS2 25 to 49, it is risk factor control and secondary prevention. For RATS3, 50 to 59% stenosis, further evaluation is required. Whereas for RATS4 and 5, RATS4 is basically 70 to 99% stenosis, and AS is instant restenosis. 4B is triple vessel disease, more than 70%. RATS5 is chronic total occlusion. So here, in addition, they require anti-ischemic therapy, coronary angiography with or without revascularization. 2016 NICE guidelines recommended CTA as a first test regardless of pretest probability. There was significant reduction in the events in the NICE cohort. Besides, CTA was most cost-effective first-line investigation. 2019 ESC guidelines gave a 1B status for evaluation of chest pain in whom CAD could not be conclusively excluded by clinical evaluation, and also for vasospastic angina, and 2A as an alternative for stress imaging, and 2B estimation of coronary calcium score, and also for evaluation of high risk but asymptomatic adults who we had just discussed. The AHACC guidelines gave a class 1 recommendation for the intermediate risk patients with chest pain, for patients with prior CABG, and patients with suspected acute aortic syndrome or pulmonary embolism, what is known as a triple rule out procedure, and a class 2A recommendation for intermediate risk patients with chest pain with various subsets. And again for those with previous coronary revascularization, and class 2B for intermediate high risk patients with a negative chest test but in whom there is a high suspicion of CAD, and also for patients in whom acute pericarditis is suspected. So the same has been incorporated in various flow charts. So this is a situation of acute chest pain, intermediate risk with no known CAD. If prior testing was inconclusive, then CCTA followed by FFRCT was recommended. Whereas if there was no prior testing, then CCTA first and followed by FFRCT depending on the degree of obstruction. Acute chest pain, intermediate risk with known CAD. If the patient previously had non-obstructive CAD less than 50% stenosis, then CCTA followed by FFRCT. Stable chest pain, no known CAD, they are first triaged into low, intermediate, and high risk. So low risk patients, coronary calcium is recommended, and thereafter in intermediate risk and high risk patients, CCTA is recommended, and then FFRCT for 40 to 90% stenosis, or a stress testing, and based on the results of stress testing for the evaluation. If the patient had mild ischemia, it is coronary artery calcium. If it is inconclusive, then CCTA. Stable chest pain with known CAD, If the patient had less than 50% stenosis, CCTA and FFR CT, and in those with more than 50% stenosis, failure of guideline directed medical treatment or high risk features or frequent angina, CCTA is recommended prior to revascularization. CCTA has been compared with invasive coronary angiography with more than 50% diametric stenosis and also with FFR less than 0.8. So the findings were that with ICA, that is invasive coronary angiography as a reference, then CTA, MRI and PET were more sensitive and specific. Whereas if FFR was used as a reference, CTA, MRI and PET were more sensitive, but only MRI and PET were specific. CTA was the least specific. However, specificity was increased with addition of FFR and CT perfusion. These are various RCTs for CTA like Scott Hart, Promise, CAP and Crescent. It was found to be cost effective and the radiation exposure was also less as compared to invasive coronary angiography. So these are the conditions where coronary CT angiography is recommended. The relative contraindications like high and irregular heart rates, high calcium, anxiety, obesity, pediatric patients, pregnancy, contrast allergy, chronic kidney disease, use of sildenafil. It is a very useful modality for diagnosis of congenital coronary anomalies. This was a patient who was 50 years old who was being treated as idiopathic dilated cardiomyopathy, but a CCT proved to be a case of adult Al-Kappa. Of late, there are societal recommendations for use of CTA prior to revascularization strategies like as it provides clinical insight for the interventionalist. Adverse plaque features are associated with high degree of periprocedural MI, like the napkin ring sign is associated with low flow, and similarly, the high risk plaque features are associated with many other complications. And if extensive calcification is present, then rotablation or intravascular lithotripsy can be planned. So again, about CTA guided PCI, there are various PCI scores. Similarly, CCTA can be used prior and after CABG, including redo CABG, wherein adhesions can be detected and it can guide the surgeon for limb dissection. So to conclude, it's a first line test for evaluation of patients with no known CAD presenting with chest pain for coronary anomalies and after revascularization. It's a reasonable test for patients with known CAD and when stress imaging is inconclusive, for patients after stenting, before non-cardiac surgery in young patients with low intermediate probability CAD, and also as part of triple rule out procedure for patients with suspected acute aortic dissection and pulmonary embolism. I thank you for your attention.